We hope you enjoy this video for diabetes professionals on virtual SMBG data interpretation. Please share your feedback in the comment section and do subscribe to make sure that you don't miss any new content that we upload. My name's Hope Frost and I'm delighted to welcome you to today's Diabetes Virtual SMBG Data Interpretation webinar. On behalf of SBK Healthcare, I'd just like to say how proud we are to produce this event, and we do hope that you find it useful. I would also like to thank the sponsors for today's webinar, who are Roche and AgaMatrix. It is now my pleasure to introduce your webinar leader, Dr. Rajeev Raghavan.
Hello guys, hello folks out there. Thank you to SBK Healthcare for setting this up and give me an opportunity to present to you guys and share my experience, and also hopefully hear from you and how you're coping out with the pandemic out there and how you are managing your diabetes clinics virtually. And it's also an opportunity for me to learn from what's going on out there. So thank you very much, and we'll try and make a start. Right, so I work in Wolverhampton, and we've got a huge population of people with diabetes that we manage, and I'm sharing some of my experiences with you, and I hope that you find this useful. My thanks to Dr. Ian Cranston, who did the previous webinar and did an excellent job of taking us through virtual consultations and how to get home devices uploaded, and some basics about using data safely and effectively. I've, with his permission, borrowed some of his slides so that we can build on what Ian presented on. And if some of you did attend that webinar, hopefully we'll keep that part of the presentation brief. And for those who didn't, then I would strongly advise you to take some of the hints and tips from here, but also go and try and get Ian's webinar so that you can get a more detailed idea of how to set up virtual consultations and home device uploads. I'm going to mainly concentrate on using data safely, some examples of interpretation from my own practice, and signposting to further resources, and hopefully the Q&A at the end. So for those of you who weren't around for Ian's webinar, this is a quick guide to how you might set up a video consultation, and essentially what are all the things you need, the kit and so on, and how you might go about trying to check some basics, making sure that the patient at the end of the phone is actually the patient you're speaking to in terms of data identity and so on, and also using triage quickly to see if this is a routine consultation or is going to turn into a more urgent one. If you already haven't got a structured way of approaching things during this pandemic, and subsequently when we are having to perhaps limit the number of face-to-face consultations, this slide from the London networks is very helpful, and it would be a good way to start off thinking about what needs to be face-to-face, virtual, and what can be deferred or perhaps looked at it in a different way. So I would strongly encourage you to think about it in a structured format in your own practice, wherever you are, and we're following similar things in Wolverhampton. So in terms of virtual consultations and what you might want to be getting on with and not leaving for another day, these are the sort of examples that would be recommended for using a virtual consultation to try and sort of get a plan together for the patient, and making sure that they are safe in what they're doing and that we can get them the help they need, even if we're not able to see them face to face. So what do we need for virtual? Again, these are all simple things that I'm sure you would have thought about in your own practice. You need a secure connection, you need good Wi-Fi, you need a strategy in place as to how you're going to collect the data, how you're going to store it, how you're going to report it back to the patient's electronic record, and how you're going to keep the patient and their primary care practitioner informed. You also need a motivated person with diabetes. What's interesting is, whilst we've had the defaulters and the DNAs that don't normally turn up to clinic, one would hope that with virtual and the fact that people can be reached anywhere they are, one would expect more people not default appointments. But we find in our practice, certainly in the clinics I've been doing recently, that there is still a default rate in that sometimes you're not able to get hold of a patient. They don't respond to your calls despite being notified of a virtual appointment, etc. So you do need a motivated person with diabetes at the other end. And given some of the constraints that virtual places on us, it's all the more important that the in-person with diabetes is motivated from their side to be able to achieve some of the things we need to achieve in order to share data reliably and help them. So providing good diabetes care, this is how I view it. I mean, you need, at the end of the day, to achieve your treatment target, you need the patient. This is patient-centered care that chronic disease emphasizes, making sustaining change, and we need understanding from our side, but we also need reliable data, and that's what we're going to be focusing on today. So these are some of the tools, the ones highlighted in red I've got experience with myself, the others I haven't, but these are tools that you can use in your own practice to set up video consultations or even phone consultations, etc. And they work very well. AgaMatrix particularly is very easy to use and is safe to use even from, say, a home setup if you were to be working from home. So I would encourage you to obtain a work phone or device ideally, but some options work safely on any device like AgaMatrix, for example. We know that having data is important, and there's enough evidence out there, published studies, etc., which tells us that evidence-based intervention support is a must. And especially without the patient being there in front of us, it's all the more important that we have good data for virtual consultations. And some of this involves preparing the person with diabetes in order to share data. And while some of our more tech-savvy users, pump users, etc., are used to sharing data, many others may not be yet prepared for that, and that's one of the challenges that you'll have to face. It's a great opportunity now to start virtual consulting because there are less barriers in general for this. All teams, all trusts throughout the country have become less prohibitive of practices which were previously difficult to set up. Your ICT teams will be tasked with this being a very high priority in order to make sure that more patients are reached virtually so that we can continue to work during this pandemic. So sharing data in 2020, you have your NHS systems behind a firewall, and you have various other systems that the patient uses, their monitoring kit, their laptop, maybe their smartphones increasingly, and you have various systems like DiaSend, MySugar, etc., which help you connect these two interfaces and get over the firewalls and get data sharing effectively. So again, I highlight some of the phone-based apps like MySugar and Diabetes, which are very, very helpful, where you can get a PDF across to you if you can't access the data directly. You can also use Medtronic CareLink for those who are on Medtronic pumps, LibreView for those who are on Libre, and various other devices. DiaSend and which is brought to you by Luco, is the UK de facto standard, and that's what we have set up in our practice for many years now. And when patients attend clinic, they get their meters downloaded, all their devices downloaded, and many of them share from home as well on a regular basis, which is very, very helpful. But increasingly, even in our own practice, what I'm finding now is that because patients are not able to come onto site, it's important that they are able to do their uploads at home so that we have this data to view virtually, and encouraging more and more patients to be able to do this is a must moving forward. What about yourself? You'd have to check whether your practice has a DiaSend account. Otherwise, DiaSend are offering free account setups through the course of 2020, which is really a good offer. So I'd encourage you strongly to look at that. Look at the device you have. You might need cables and connectors if the connection is being undertaken, the upload is being undertaken by you. With the patient, usually every meter that the patient gets comes with a cable, or they can request a cable from the company and be able to upload. There are also cable-free upload options. I won't dwell on these too much, but these slides are available for you to look at. We use the AgaMatrix WaveSense Jazz particularly in our antenatal practice for all our pregnant women, and increasingly we've used the Jazz in other areas as well because of its Bluetooth connectivity and so on. And there are other similar devices out there which function in a similar way, like the AgaCheck Mobile and so on, which connects to the MySugar app. And the benefit of this is the patient doesn't have to manually then take data and put it into another app, but the data is Bluetooth, and then that could be sent across to the healthcare professional for sharing. And there's also app-based uploading available through Diasyn. Well, when everything else fails and we still need data for consultations, sending out a structured monitoring chart or getting the patient to use a diabetes diary to transcribe their data, and then viewing this on screen with the patient, or perhaps the patient scanning and emailing it to us or sending it by post, are options available which can be utilized. So make sure that you have the date and time setting right, and make sure that we're encouraging home loading, uploading and sharing. Make sure that we have our own account set up and we know how to access them, and encourage structured monitoring, and we'll talk about that briefly. Moving on to sharing blood glucose data in consultation, it's always important, as in any consultation, whether it be face-to-face, virtual, telephone, etc., that we first get to know the person, how they're doing, how things are, get to know what's going on in their life before we get to the data, because that's really important. Sometimes we may not be able to get to the data because there are bigger things happening in the person's life, and it's more important to recognize that. Otherwise, we would be wasting our time reviewing data, perhaps when it's not a timely situation to do so. Then it's about reviewing the data with the patient, and I'll give you some examples of that, trying to make sense of what the data is telling us, and then getting some explanations from the patient, giving them some explanations, and coming up with a plan. It's good to think about data in terms of what it's telling us, both about the behavior of the patient and the structure of their therapies. And it's important not to try and jump into making interventions early, but to first understand why there might be variability, why there might be changes that are happening, why there are ups and downs, and so on. And also getting the person with diabetes to think about it themselves as they are living with their diabetes, and getting them to think about it and giving them the skills to think about it is going to last much longer and be more effective than if we jump in with a plan. So empowerment, we use that word a lot, but it's really important in this sense when looking at data to get the patient to think about it, for them to be making those decisions, and as much as possible prompting them to get to where they need to. Where there's lack of data or missing data, having empathy, making sure that we understand where the patient is, and encouraging them to move from where they are to a better position. The more time is invested in diabetes self-care by the patient, the more returns they get, and that's the message we should be driving through virtual and face-to-face consultations. When it comes to looking at data, we have to recognize that just looking at a mass of numbers or lots of lines on a graph, we could try and make very facile interpretations about it, but we need to be mindful of the fact that there could be variability within the person's day-to-day life, which includes variability on a given day, or it could be variability that comes across the work and the week that the patient experiences. Looking at simple ways of data monitoring, and again, many of you might be aware of all of this already, but just a quick pointer, you can have various ways of monitoring glucose. If a person with diabetes doesn't have LibreView, which captures all of their data, or CGM, etc., then having some sort of structured monitoring is helpful for us to work out what's going on, and for the patient themselves to understand what's going on. So for example, a 4-point profile would be one that's done before meals and at bedtime, and a 7-point profile, which is illustrated with the combination of basal insulin monitoring and meal pair monitoring, would be a 7-point profile where you'd get readings before meals, reading 2 hours after every meal, and at bedtime, to give you 7 points, which allow you to analyze what's happening with glucose and variability. If you have to focus mainly on hypo risk monitoring, then the most common risk for hypo is post meals, and this would be and perhaps before evening meal when there's more activity and so on, and that could be a way of monitoring. And if you want a simple pattern for someone who's very reluctant to monitor, or where you need basic information before you start to delve deeper, then having this sort of pattern might be a way forward, which encourages the patient just to take a couple of checks a day, but still get data which allows us to look at the pattern across a week or 2 weeks. When you look at visualizing data for analysis, you have various ways of looking at it, and these are two common ones, which is the trend graph, which is the longitudinal analysis. So you have dates across the bottom here, and it tells you what's happening with a person's glucose. And the importance of looking at it this way is that it gives you an idea of whether things are changing over time, and whether there are clear patterns emerging longitudinally. Looking at a cross-sectional analysis gives you a standard day. So when all the days of the week are laid across and onto one single graph, which is then set out from midnight to midnight, gives you an idea of how the patient's spread of data is, glucose data is across the day, and whether there are patterns emerging which can be used to interpret what's going on with them and help them. Structure is important to our own evaluation of the data and helping patients understand their data. So it's important to know what we're looking at. The scale of glucose on the left-hand side. What is the time of day across the bottom? You can talk. Some softwares allow you to toggle to change to different times of the day. For example, you could do midnight to midnight, or you could do noon to noon to get an idea of different patterns within the day. It's also important to focus on what we're trying to achieve, which is good diabetes control, and trying to look for outliers and variability, which tells us about patient behavior. A longitudinal look might also help us understand where there's been variability across time, i.e. where this person, for example, had very high readings between these dates, and then things seem to improve, but that made them prone to hypoglycemia in the second part of this graph. It's also important that we understand why behavior influences glucose and variability, as otherwise we'd be making changes which might not be beneficial to the patient in the long term. Structured evaluation also helps us to understand what are the reasons behind why patients might be having hypo and hyperglycemia, and also to understand the reasons behind sudden drops or elevations in glucose. One way of looking at this, which is very helpful, and I follow in my own practice, is to look at sectional analysis of structured testing and making sure that we've gathered all the information that the patient brings, including their background, their other health conditions, how they're feeling, what's going on in their life, and then to go about in a structured way looking for hypoglycemia, first of all, frequency, the time of day, circumstances, whether it's before or after a meal, what else might have precipitated the hypoglycemia, whether it was a one-off or a recurrent theme which needs addressing. It's also important to bear in mind about hypoglycemia awareness in this context, and to ensure that we are able to make judgments as to whether what we're seeing is valid. Then addressing hypoglycemia also addresses the patient's main concerns and fears, and perhaps helps us get past the barrier of hypoglycemia, preventing further improvements in diabetes care. And hypoglycemia also poses the most important risk acutely to a patient. Then moving on to look for fasting hyperglycemia, which again gives us an idea of basal insulinization, also gives us an idea of how a patient's best glucose readings might be, given that they have not eaten anything, and one would expect that this would be their best glucose reading of the day. Looking for postprandial hyperglycemia then is the next step, and again is helpful with paired testing, where data from devices such as the Libra are not available. And again, it's important to know when somebody is having meals in order to interpret this data. So looking at pattern recognition, we could look at this example here where you're getting high glucose readings first thing in the morning, and then you see what's happening post breakfast, around lunchtime, assuming that the patient is having lunch here, and then look at what's happening mid-afternoon, before evening meal, post evening meal, and at bedtime. And that gives you a good way of sort of focusing on different time points within the day, breaking them up into segments in order to understand what's going on and asking the right questions of the patient in order to obtain the right information. This here illustrates a very good pattern of postprandial rise in glucose with subsequent drops, perhaps suggesting that there might be issues with the balance of insulin, carbohydrate counting, understanding of carbohydrates within a meal, etc. It's important to address this. You can also see that the patient's going to bed with very high readings and then waking up with low readings, suggesting that there's a significant drop in insulin overnight, or perhaps the patient is deliberately pushing their glucose readings up come bedtime. This is a common pattern that we see where people get highs, they panic about those, they try to correct them, perhaps too aggressively, they go low, and then they're treating the lows, going high again, and then going down again. And we see this yo-yo pattern of diabetes care, and it's really important to recognize and address the factors behind this. CGM data, which looks like this, makes pattern analysis easier. It's essentially taking all of the glucose data and trying to map it out in an easy to read way and a standardized way, and gives us a visually easier picture to see, which makes data interpretation much more easier. You can also get a lot of data which can be easily put into a graph like this. And if you want more information on how to analyze Libra data and AGP data and understand how to read all of this, then I would encourage you to go to agponline.org and sign up to the free webinars, free educational resources that they are offering currently as part of the COVID-19 pandemic. I would strongly encourage this. So if all goes well, this is what your patient's graph might look like. And the more patients we can get looking like this, the better. So moving on to specific examples. Now, when you look at an SMBG logbook, this is what you might get to see initially. You would get the spread of glucose readings across the day. This is very structured testing, as you can see, before meals and bedtime, what we call a 4-point profile, and it gives you a good, easy way of analyzing information, even without graphs. But the color coding also highlights what is in a good range, in green, what's high in red, above 10 millimoles per liter, and what's hypoglycemia in purple. And again, it's a easy visual way of making out what's going on. This example is a 19-year-old patient of mine with transitional, who is in the transition clinic with type 1 diabetes. And we got this data at a clinic consultation recently. Now, one could say that there's not much here to see, and the patient should be undertaking more structured testing. But before we get to that, perhaps we can use this data to some extent and make changes already. For example, asking questions about the hypoglycemia that one sees around midday is very helpful, and trying to address that is important. Looking at a pattern of very high glucose before bedtime, which then with drops overnight, is also interesting and should be explored. And again, this patient had lots of anxieties and concerns about weight loss, lack of periods, and needed independent investigation. And it was their anxiety which was making them take their eye off the ball with regards to their diabetes, and addressing that using this data, encouraging them, addressing their concerns, meant that they were able to engage better and give us more information at their next consultation. Here's another example of a patient of mine with lots of comorbidities, insulin-treated diabetes, COPD, requiring steroid courses every now and then, recurrent chest infections, and other issues. This lady had a lot of variability, and there were a lot of health beliefs that this lady had, which we needed to try and address in order to get somewhere with her variability. Looking at this graph here, you could see, for example, that that this lady is monitoring four times a day on average, and again you can see that there is a structure to that testing, which is really important. You can see that the period average for the last 2 weeks is 13 millimoles, and the standard deviation on that is 6.3, suggesting a huge amount of variability. There's also hypoglycemia in the first part of the day and high glucose readings, which are predominantly spread throughout the day. And it's important to address the hypo and also think about what's going on as to why this lady is getting high readings throughout the day, but then there is a rapid drop overnight. This is a longitudinal or trend view, again illustrating that the spread this is a consistent pattern across a couple of weeks. And you can see what happens when we group the data points together with regards to the rise in glucose as the day progresses. If you do a midnight to midnight, if you change it to a noon to noon view from the midnight to midnight view, you can see that there is a drop in glucose readings from bedtime through to the morning. And this needs to be addressed as there is a risk of nighttime hypoglycemia. And it's also important to understand whether the patient, what's happening with the patient's insulin or through the course of the day. Now, as it turned out with this lady, she had a significant fear of taking quick-acting insulin because she had problems with the fact that she used to go hypo whenever she took even a small amount of quick-acting insulin. And so she used to run mainly on basal insulin with very little quick-acting insulin being taken, which was explaining this pattern. In order to understand this, initially I thought it might just be her health belief, but when we dug into this further, it became clear that she had significant pancreatic exocrine insufficiency from chronic pancreatitis and wasn't taking any creon supplementation, which was leading to issues with malabsorption. And that meant that she was just eating without taking insulin because of the fear of hypoglycemia during the day, and then relying on the basal insulin to get her to a better target come the morning. Addressing this meant that we could try and improve on this profile and hopefully change her variability patterns. This is another patient of mine whose 14-day record looks at first sight really difficult to interpret. I mean, there's a lot of data points here. How do we even start to make sense of this? This young lady was monitoring nearly 12 times a day, as you can see here, with a period of average of 10.2 and standard deviation of 4.1. Again, these are useful measures to look at to get the spread of the data, and the standard deviation tells you that there is variability going on. Hypoglycemia, there were 10 values in the 14-day period, and again, they're easily highlighted in the purple here, and you can see that the spread of hypoglycemia is present throughout the day. Now, when you get data like this, and there's lots of data points to look at, an AGP graph would be useful, but another way of doing it is to perhaps reduce the number of days you're looking at, or to do the day-to-day analysis alongside with and speaking to the patient to get more information. So this is what the graph looked like for this young lady, and she was very anxious about her diabetes. She was testing a lot because she was worried about highs. She was also worried about going low. She had issues at work, which meant that she was felt that she was being bullied, and this was playing on her anxieties as well. And you can see here that the blue graph, the blue line in the middle, which gives you the median for different times of the day, might show that there might be some postprandial elevations in glucose. That's one way of looking at it. But it also tells us that there are a lot of high and low values contributing to this lady's median graph. Focusing on the hypos, it was really important to understand why this was happening and to try and address these factors before we moved on to looking at the highs, shaded in blue here. And this is a good exercise to talk to patients about, where they're doing well most of the time, getting them to focus on hypoglycemia and trying to eradicate hypoglycemia, and then moving to the real outliers and understanding why these high data points are occurring are one way of trying to address the problem, because that's what reduces the variability. You can then focus on the different times of the day, i.e. around breakfast time, post-breakfast, then around lunchtime and post-lunch to see if there's any patterns that emerge, and then looking at the evening time and moving on to bedtime and seeing if the bedtime readings are giving us any indication of patterns. This I found useful on Diasend as well. You can click on the compilation button on the top, and this brings up this donut here, which gives you a spread of the data in terms of being within range high between 4 and 10 millimoles per liter in green, below range, which is here in purple at 6%. So this again is useful to talk to the patient about, as this gives them a good objective measure of how their diabetes is doing, and for us to compare across time points and consultations whether progress is being made. At the end of the day, when we've looked at all of this, sometimes there's no substitute to going to the day-to-day graphs and trying to sit with the patient and work out how what certain things are happening. For example, here you can see a pattern of hypoglycemia followed by a high and a subsequent drop in glucose, which is quite steep. Now, this is the yo-yo pattern that we were referring to. This is a case of where there is overtreatment of hypoglycemia leading to high glucose readings, then overtreatment of the high glucose readings due to anxiety, which then leads to hypoglycemia or near hypoglycemia. And trying to address these factors are important when it comes to making a difference to the patient. A quick word about glycemic variability, which is really important to understand. There are many, many factors which can underlie variability, and I give an illustration of understanding this through getting the patient to think about driving and how they might encounter different obstacles while driving. Looking out through the windscreen is in a sense taking blood glucose readings or getting data as often as you can, various things, glucose, food, exercise, etc., which can impact on variability. And the steering of or driving the car is how the patient or health and the healthcare professional helping the patient addresses these factors, trying to navigate them without lurching from side to side and actually driving smoothly. So being proactive as opposed to being reactive is really important in this sense. I strongly urge you to look at the website for sugar surfing. This is, I find, a brilliant resource, and you can see that there are about 50 to 60 factors which underlie variability in glucose readings. And you can imagine that unless we start to understand this and give our patients confidence that they're beginning to understand this, they might find that it's difficult to address variability. Finally, I'd like to point you towards the Type 1 consultation tool, which was put out by the Health Innovation Network along with King's Health Partners, Pratik Chowdhury. This is a very useful tool in setting out a Type 1 consultation, how you might focus on getting a structured consultation with your patient. It's got a number of tools and resources which are very helpful. An objective measure, particularly when the patient is not in front of you and where you're trying to look at hypoglycemia, is important to get an understanding of their hypoglycemia awareness or the GOLD score. And this is a tool which is easy to administer and very quick. As you can see, you ask the question, how well can you detect the onset of low glucose readings or hypoglycemia, and score it from 1 to 7. And you try and sort of work out if you are able to get an objective score. Score of 4 or more means that there is a significant risk of severe hypoglycemia, and more investigation is required into this. In the interest of time, I will finish with this quick example here. This is a young Type 1 patient of mine with previous anorexia who was a farm worker. She was having a lot of issues with variability, and when we went into details, it turned out that most of her variability was occurring due to fear of hypoglycemia at work, whereby she was driving her diabetes hard, waking up with lower readings, which you can see in the purple here, and then going high during the day because of the fear of hypoglycemia at work, because her work involved manual labor, which was bit unpredictable in that some days were busier than others, and in the hope of not getting hypos, she used to run high readings. Going on to insulin pump therapy and subsequently onto Libra helped her a lot in addressing the variability and giving her the confidence to run her blood glucose readings tighter, and having a pump meant that she was able to make basal rate adjustments at work in order to address the concerns about changes in glucose. So a brief information regarding type 2 patients that you might see during virtual consultations, and particularly those who are on complex therapies, including GLP-1 and insulin, and having a structured way of going about looking at the patient-centered glycemic management. This is a useful tool that you can use in order to draw up a plan for the patient and keep them under review. This is one of my patients who was looking to run the London Marathon, but sadly it's now cancelled due to COVID-19, or I assume it will be cancelled. And you can see that this is what perfect diabetes care might look like. And a lot of effort goes into achieving this, particularly from the patient side. And even here, one might think about the risk of hypoglycemia and perhaps be overcautious or overinterpret this. It's important to look at the day-to-day graph here and understand that the hypoglycemia that we were looking at in the previous AGP was contributed to by a couple of days, and that's why it's in the light blue here. And it's important to talk to the patient about why those 2 days led to hypoglycemia and understand those factors in addressing it, rather than trying to make a more sustained change which affects the rest of their week. This is what good control would look like, or excellent control would look like. Hypoglycemia below 5%, glucose being in range more than 65% of the time, and having less hyperglycemia. So in summary, it's important that we look at downloaded data, and it allows information sharing in a more rigorous way. Look at both longitudinal and cross-sectional formats. Make sure you're concentrating on make sure you're looking for the outliers and the one-off events, and not focusing on those in terms of making structural changes, but more in terms of behavioral changes where the patient takes action to do or not do something. And it's important to get the person with diabetes to give their own view about what's going on, and get them to make judgments about their health and understand how they can make changes. It's important not to hypothesize just on the data without getting the person's actual experience. This is really valuable in getting the data interpreted properly. And finally, a plug for more people going on to devices like the Libra, as this gives us a wealth of data, which is really helpful to make healthcare easier for particularly people with type 1 diabetes. I'll finish at this and welcome any questions. I have got a few more resource slides in case people have any questions, which I can pull up as necessary.
Thank you, Rajeev. That was really insightful. We have got a couple of questions that we can run through. The first one that came up in the chat is, could you just let us know the name of the website that provides the AGP data?
Yeah, it's agclinical.com. It'll be in the slide. When we share the slides, you can, if you have not made note of the website, it should be on there. And again, you can log in and create an account and get access to free learning resources. And I highly recommend Ian's webinar to you. He's a great blog.
Great, thank you. Next question. Do you know if the free DIASEM sign-up is available UK-wide or just in England?
I believe it should be UK-wide. I think the user is from the channel, is it? Well, somebody actually has responded to that saying, based in Jersey, Channel Islands, and have received DIASEM free. So hopefully that explains what the person's asking. But the simplest thing is to go on to DIASEM website, and they have a lot of resources as well on YouTube, and you can refer to those. Log in, create an account, and you can find out whether it's available where you are. That's the simplest way to do it, I think.
Yeah,
I've been promised that it's free until the end of 2020, and then you get a 3-month period in 2021, assuming the pandemic has ceased by then to decide whether you want to carry on with it long term.
Great. What are your thoughts on how virtual consultations will be used in diabetes post-COVID-19?
That's a really interesting question. I mean, reflecting on our own practice here in Wolverhampton, we're seeing probably less than 5% of our patients at the moment face-to-face, only those with pregnancy issues, foot issues, and urgent care, such as needing an insulin startup or education for newly diagnosed type 1, etc. Now, I think virtual consultations are here to stay because the pandemic isn't going to get resolved very quickly. We have another 6 to 12 months potentially where we might need to practice social distancing and reduce footfall within hospitals and secondary care and even in primary care, and therefore virtual consultations will be here to stay. Now's the time to get set up because you get the resources you need, you get support from your IT guys who were previously reluctant due to various issues, and I think this is here to stay for the long term, because once the genie is out of the bottle, as they say, you can't put it back in.
Okay, great. Someone else has asked, do children with type 1 diabetes, are they considered high risk?
The data available before I think we're still analysing the UK data, but I believe NHSE and Parthacar are working on getting information. The information from outside the UK suggested that children and adolescents with type 1 weren't at higher risk compared to the general population with COVID-19, and I suspect the UK data will back that up as well.
You mentioned patients.
To say we shouldn't take precautions, because even the general population, even healthy people, are at risk from this pandemic. They might be at lesser risk, but nevertheless, people still are at risk. And the baseline risk is still high enough for us to make sure that we are following all the precautions. So stay home, stay safe, or if you are going out, then follow all the precautions you need to.
Okay. You mentioned patients need to be tech savvy to participate in remote consultations. In your opinion, what percentage are tech savvy, and what percentage of NHS staff are tech savvy?
I think the simplest answer to that I can give you is to look at smartphone use across the wider population. If you have a smartphone, I think you're probably savvy enough to use a technology which is required for things like diabetes virtual consultations. There are very few people, I would say, in my practice where we haven't been able to give them anything. And the reason behind that is either they don't have a compatible smartphone, or that they don't have a laptop at home which allows them to upload. So those are the two barriers that I can see. But other than that, majority of people, even if they are not now able to do it, with encouragement and support, will be able to do it.
Yeah, wonderful. Someone else has got a kind of related question, which is, have you or anyone got experience of how to support people without access to laptops? So for example, they've only got an iPad or a similar tablet and they don't have USB ports to plug the meters into.
I think the devices like what I was alluding to earlier, which is using sort of non-cable-based applications and non-cable-based data transfer. So things like using Bluetooth, etc., would be a way forward. So Diasend allows for that on some platforms, and it's worth exploring that. It's also worth exploring apps which allow you to transcribe the data into them and then share it across with the healthcare professional. So for example, let's say a patient's got a meter which is not Bluetooth enabled, but they have the data in there, they're monitoring every day. If they could put that into the app manually, it's still a way of getting the information then across. So instead of them writing down in a diary, all they're doing is they're putting that information into an app, and the app then allows for the data to be sliced and diced, put into a report, which can then be looked at by the patient and also shared with the healthcare professional. It does involve work, no doubt. It's not the same as if it was all automatic. But if we then go back to when we were using diaries and meters and writing down stuff, this would be a step forward in that direction.
Someone's asked if you could explain a little bit more about pattern to use with suboptimal monitoring to get 2-week data.
Sorry, say that again.
Could you explain a bit more about pattern to use with suboptimal monitoring to get the 2-week data? It was on your 4.7 profile slide.
Okay, so when you say suboptimal monitoring, I'm guessing you're saying where patients are not monitoring 4 or 7 times a day and they're doing less. I guess the question then is, are they doing it at times which are useful? And my take on that would be the most useful times are to start with, if you can encourage people to do before meal testing, because it still gives some idea of control both for the basal insulin and also post meal insulin, in that even if there is a post meal rise, there is some carryover to the next meal which can be useful to look at. So at the very least, if we're looking at structured testing, and if patients are only willing to undertake a couple of checks a day, for example, then encouraging them to do before breakfast and before evening meal one day, before lunch and before bed another day, and so on, over the course of a couple of weeks helps us build up enough of a pattern in order to see if there's any obvious changes that could be made to their profiles and their treatments.
Okay. Pregnancy tends to result in a lot of glycemic variability. What tends to be your approach with this, with your pregnant patients?
That's a topic of its own. I think maybe SBK should be putting up another webinar on this. here's a thought. But to answer quickly, I mean, I think pregnancy is also a time when women are most motivated, and you get lots of information. They do all the right things. They do all the checks that you ask them to do. So it's hopefully easier to come to patterns. I find that probably the hardest thing to set right is post-meal excursions of glucose, and particularly around breakfast time. And it's important, therefore, to try and sort of work on a few simple strategies which we use, which is to look at what the patient's eating. First of all, diet's always important, regardless of the type of diabetes, gestational, type 2, type 1. Followed by and limiting the amount of carbs, particularly in pregnancy, is important. Even for our type 1 patients, we tend to say to stick to less than 60 grams of carbs per meal in order to reduce variability, because if you think about it, the more the carbs on a plate, the more likely the estimation error, the more likely the insulin absorption error, and so on, and it all builds up. So keeping carbs limited, not restricted to the sense where it's going to affect the pregnancy, but not a low carb diet, but we're talking about a carb restricted diet is important. Pre-meal bolusing, and sometimes even having a bolus 30 to 45 minutes before a meal is useful, depending on what you're seeing on the profile. And we've used that in some patients successfully to try and get control of their postprandial spikes, because the issue is they get a postprandial spike. In order to address that, we keep increasing their mealtime insulin, and then they end up with delayed hypoglycemia. So it's important to get that right, and particularly the timing of insulin. And even with an insulin like Fiasp, which is supposed to be the fastest absorption time on the market, you would still want to be looking at pre-meal bolusing, and perhaps 10 to 15 minutes before or earlier, depending on what you're seeing on the profile.
That's great, thank you. So next question. On diabetes.co.uk website, our review of type 1 diabetes management suggests that GPs may wish to stop SGLT2 during COVID, as COVID can mask symptoms of DKA. What advice have you been giving patients around this?
The question, I hope it's not a typo when you said type 1 and SGLT2. I mean, obviously, very few people with type 1 should be on an SGLT2 inhibitor, but increasingly there are. I understand that. We're seeing type 2, a lot of type 2s on SGLT2 inhibitors, and the risk of DKA does remain in this population, and we need to be aware of euglycemic DKA. I had a case recently of COVID admission in a very well controlled type 2 patient. They weren't even on an SGLT2 inhibitor, but they had a DKA episode which was unexplained and was attributed to COVID-19. So the answer to your question is we're not giving specific advice to stop SGLT2 inhibitors in everybody that's on them, because that's I don't think we have enough evidence to support that. But equally, we should be advising patients to keep themselves hydrated and be more vigilant about the signs of euglycemic decay and have access to ketone monitoring if they need to. Particularly for type 1s, they should have, I would encourage you to use the sick day rules. I can share a slide with you if you like. But sick day rules, all type 1s should have access to sick day rules. All type 1s should have access to ketone monitoring and be vigilant about the signs of euglycemic diabetic ketoacidosis. If you have type 1s out there who are on SGLT2 inhibitors, and again, I don't think we need to go and stop them in everybody that's on them, but certainly giving abundant caution around how they view data and how they view any symptoms that they get is important.
Okay, wonderful. And did you say you had a slide that you were able to share around the sick day rules?
Yes, yeah.
A couple more questions. Someone said, thank you for a great talk and advice. How much time do you get for your virtual clinics?
Whilst I'm pulling up this slide, I'll try and answer that on the go. Anybody out there that thinks that virtual consulting can make you get through more patients than face-to-face, I think are fooling themselves, because it takes as much time, if not more, for virtual consultations, because of the fact that you're not getting, particularly if you're just doing it on the phone, or even if you're setting up a video chat, it takes time to set up these things and time to get the patients on board. Sometimes you have to ring or call more than once in order to get through to a patient. So all these things take time. So if you build all of that in, I would say you pretty much are able to do the same as you would in a face-to-face consultation. But from the patient's perspective, they're not spending their time getting to hospital, queuing up in the car park and all these other things that happen. So from a healthcare professional perspective, I would put aside the same amount of time, if not more, in order to get things done. So if I share my screen again, hopefully you're able to see this. There you go. So that's the, that's a quick aid memoir for how you might think about drugs that might have an implication in acute illness. SADMAN, SGLT2 inhibitors, ACE inhibitors, diuretics, metformin, ARBs, and NSAIDs, which need to be discontinued if someone's acutely unwell. There's been a debate about whether ACE inhibitors need to be stopped, ARBs need to be stopped in people who are taking them, but the consensus is not, and it needs to be only in the event of an acute illness and dehydrating illness that you would think about stopping these things. General advice, and also you can make sure that patients have ketone monitoring strips on their repeat prescriptions.
Okay, wonderful. So we've got time for another couple of questions. So one is, have you noticed changes in patient engagement from face-to-face consultations to remote? What do your patients prefer?
Patients are generally very grateful that they're being rung where they thought they were not going to have any appointments, which is the first thing to say. So many of them are grateful that somebody is interested and talking to them about their diabetes. One example was a chap who had defaulted his appointments as he had a very busy job running a coach business, and he was unable to make his appointments on many occasions, and he was seen as a defaulter, but actually the truth was he was just trying to earn his living, and he couldn't get his appointments. Having a virtual consultation meant that he could step outside the door for for 15 to 20 minutes and talk about his diabetes, and we got a plan together. So I think there's going to be more people that are willing, particularly those who are working, who have got busy lives, who are going to be willing to have virtual consultations. Even before this pandemic hit, we were using LibreView and Freestyle flash glucose monitoring in order to facilitate teleconsultation and email consultation with our patients, and that has really revolutionized the number of people that have been able to get better diabetes care and get help with their diabetes.
Great. We've got one last question, which is, When the patient reports that when they eat, they take a 3:1 ratio of bolus and there is a postprandial, their postprandial is still too high, but their basal is a low dose. And if they forget to take the basal several times, it makes no difference on their Libre graph. What would you advise?
So just to rephrase the question, I think you're asking about the patient being on less basal and they're taking plenty of quick-acting insulin and they're still getting postprandial spikes, and you're wondering about whether, and even when they leave the basal out, they're not seeing a difference. Well, if the basal is little, I suppose it's not going to make a difference anyway, and it's the one way to look at it. So, there is a case for seeing whether amplifying their basal might help, but another strategy is, before we go to all of that, is really important to look at whether they are, adequate basal insulinization. There's ways of checking it out. You can use a weight-based estimation. You can also look at fasting profiles in some instances, if the patient's able to undertake them, to see whether they're getting good baseline control without the mealtime carb coming in to cause elevation in their glucose readings. And then the other factors that really need to be looked at also are how good are they at that carb estimation. They might be taking a good amount of insulin, but is that carb estimation way out for that particular meal? And it's really important to assess that. Apps like My Sugar and so on now have visual cues, photographs that can be taken and put onto the app, which can be shared with the healthcare professional, so one can get a quick understanding of whether somebody's on their ballpark for carbohydrate estimation or not. Using other apps like Carbs and Cals is also very, very helpful in order to make sure that people get their carb estimation right. Again, that's really important to do before we start to address whether the patient needs more insulin and whether they need the basal change. So I would get those queries sorted out first before making further changes to this patient's regimen. The other thing that I commonly find is, unless you ask, many people take their insulin after they eat, not before. And this is sometimes just habit, long-standing, sometimes fear of hypoglycemia, fear of not knowing what their carbs are, and so on before they eat. So it's important to encourage them to do pre-meal bolusing, even for injections like Fiasp. As I keep emphasizing, they need to be taken before a meal as often as possible.
Okay, that's great. Thank you so much. That is all that we've got time for today. But thank you very much, Rajeev. It was very insightful, and I know that we've had some comments of thanks come through, so thank you. I'd also like to thank all of you for taking part in today's webinar. We do hope that you found it useful. I'd also like to thank Roche and AgaMatrix for their kind support of today's webinar. And finally, we'd just like to thank you. Everything that's going on at the moment is challenging, but we appreciate all the hard work and support that you are delivering to the country. So thank you very much, and goodbye.
Thank you.